Welcome. My name is Cynthia McCullough, and I'm the Director of Sales and Product Development with Goodwin House at Home. We'd like to thank you for joining us today for Avoid Chaos, Plan Well to Live Well as You Age. Before we begin, I just want to take care of a little housekeeping. What you will see this afternoon is our featured presenters. They're excited to share information that will provide helpful guidance that will empower you to age successfully. After the presentation, our presenters will answer questions. We encourage you to submit your questions by typing in the questions pane on the control panel. By clicking the question mark, that will allow you to see your questions. Without further ado, it's my pleasure to introduce you to our moderator, Lindsay Hutter. She is the Chief Strategy and Marketing Officer with Goodwin House, Inc. Lindsay?
Thank you so much, Cynthia. It's a pleasure to be here, and I want to echo your welcome to all of our guests across Washington, D.C. and the Northern Virginia region. It's a pleasure to have you with us this morning. So if you look closely at this picture, I hope you see that I'm the one on the right, my brother is the one on the left, and our dear mother is the one in the middle. And I share this picture to show that I am a daughter first, and then I'm a Chief Strategy and Marketing Officer. And many of us in the Goodwin House Incorporated family have parents or older aunts or uncles or older loved ones that are served by Goodwin House or served by other senior living organizations. And that makes this very personal to us as much as it makes it very professional to us. So with that, let me tell you a little bit about the next 60 minutes and share with you our agenda. As Cynthia noted, we have two outstanding speakers, Howard Gleckman of the Urban Institute and Tom West of SEIA and Life Care Affordability Plan. And you're going to get to hear from both of them, about 10 minutes or so from Howard and 10 minutes or so from Tom. And then we're going to go into some questions. We've received some questions already from our audience. And as Cynthia noted, you can enter your questions in the questions pane on the right side of your screen, and we'll take as many as we can. Let's now just take a moment to tell you a little bit about Goodwin House. Some of you may be familiar with our organization. We may be new to others of you. And so on this next slide, what you'll see is our history and our mission. Goodwin House is celebrating our 54th birthday this year. We were established in Northern Virginia as a not-for-profit organization, and we remain a not-for-profit organization. And our roots are with the Episcopal Church. And we today celebrate all faith traditions, warmly celebrate all faith traditions. And we serve now, it's actually increased since this slide was developed, about 2,200 older adults across the entire National Capital Region with our services. The Goodwin House mission is to support, honor, and uplift the lives of older adults and the people who care for them. This is a mission of mutuality for those we serve and those who serve. So, what are the ways in which we serve? This next slide is going to show you what our living options are. And by living options, I mean Goodwin House supports older adults wherever they choose to live. Increasingly, many older adults want to age in place in their home and live out as many of their days there as we can. And we support older adults who want that option through Goodwin House at Home. And that is a life care contract program that provides coverage should you need care. And it also provides care coordination, among a number of other benefits. Goodwin House Incorporated also owns and operates 2 life plan communities. These are the full continuum of care, from independent living to assisted living to memory support to skilled nursing. One is in Alexandria and one is in Falls Church. And Goodwin House is the managing agent for a low and moderate income senior housing community in McLean, Virginia. Now, that's about where you live. We also have services, as you'll see on this next slide, which help you stay healthy and age well wherever you live. We have therapy and home health services, and we also have Goodwin House palliative care and hospice. We provide these services to older adults wherever they live And we also provide these services to the residents in our two communities, as well as the Lewisville community. Now you may wonder, okay, give me some geographic balance, Lindsay. Where exactly does Goodwin House serve? And so this map shows you the services that we have in Virginia, which is where the 3 senior living communities are. We also have Goodwin House at Home across Northern Virginia, and Goodwin House at Home is in Washington, D.C. So older adults who want to age in their home, Goodwin House at Home can be their partner. We have our brain health programs, and we have many other programs that are in Washington, D.C., and even scale into Maryland. So that's just a geographic glance at who we are. And one more slide, and this is our credentials slide. We feel that you ought to know who's presenting to you today. And so a couple of these icons reflect the type of organization we are and our values. I'm going to call out 3 of these icons. The one is on the top row. It's got that yellow badge and it says Top Workplace. Goodwin House Incorporated has been a Washington Post top 10 workplace in the large employer ranking for the last 3 years. And those are the only 3 years that we have participated in that survey. So we're very pleased about that. I'd also call your attention in the middle row to the icon that's on the far left. It says Sage Care. And that is evidence of our very inclusive approach to all older adults, particularly the LGBTQ+ community. And then I draw your attention to the one icon on the bottom. It says Fitch Ratings, BBB+. You might be familiar with the rating services that exist to provide a rating of an organization's financial health. Nonprofits like Goodwin House do not need to undertake a rating analysis, and yet we do. We feel it's important that anyone that would become a customer, a resident, or a member of our organization knows exactly what the financial health is for Goodwin House. And I'm pleased to tell you that we're rated BBB+ and have been for the last 3 years. That is a very, very high ranking in terms of our overall financial health and integrity. Let's transition a little bit now to the topic that's before us. And what is that? Well, it's a bit of how to live well and age well and avoid chaos. And I want to give you just 2 quick perspectives on that from Goodwin House. This next slide says, care is not just about affordability. And why would I put this slide up here? Well, often we hear from older adults, thank you, we'll come to you, Goodwin House, when we need you. And that presumes that when they need care, they'll be able to get their checkbook out and it will be there. And yet today, care is not just about affordability. This graphic is showing you in the gray bars the population of older adults in America, 75 and over, and it's in the millions. So you see it's a very, very steady climb. And then you see what's a red line. And you see that that red line peaks in about 2025, and then it starts to really decline in 2040. That is a projected population growth in the United States. So you see that there are going to be more older adults and a smaller population of people from whom to find workers. Let me show you one more graphic that captures this also in pretty stark numbers. And that's to say that care is not just about affordability, it's about accessibility. And this graphic is the birth rates in the United States. And you see it starts at a little before 1965. And you look at the very right-hand column and you see that's a steady downward spiral. And what it's showing us as a country is that we have more and more older adults and we have fewer and fewer workers to help care for older adults. So care is going to be about affordability. It's also going to be about accessibility. One more slide before our speakers, and that's a look at what we've learned through the pandemic. And affordability and accessibility have both been impacted by the pandemic. I thought I would share what are the lessons we've learned as an operator in senior living and healthcare services about the pandemic and how to navigate any chaos, particularly any crisis that's unanticipated that comes before you. The first is excellence. If a provider you're thinking about has a demonstrated track record for excellence and discipline in all their protocols and their safety practices, Good chance that they'll weather that storm. If you're considering senior living providers and partners to help you navigate your retirement, and they pay attention to their talent, they nurture their talent, good chance they'll make it through any type of crisis and they'll be able to take care of you. Third lesson, transparency. There were many senior living organizations that did not communicate even with their residents or those they serve what their COVID situation was, much less with their families and loved ones. Goodwin House set up a newsroom during the pandemic, and we literally reported every day what was our situation, if we had any positive cases, what were they, what were the circumstances, what were our protocols. And that transparency paid a lot of dividends because our residents, our Goodwin House at Home members, our staff knew they could trust what we were telling them. They were always informed. And finally, team building. Now, team building is not just internal, it's also external. And one of the things that we experienced, as everyone did during the pandemic, was supply chain challenges. You may remember back in March and April of 2020, there was no PPE to be had. When testing came out, it was very difficult to get the COVID testing kits. So Goodwin House cast a wide net, and we said we're going to have a stable of business partners. So if any one of them falters, we're not dependent on just one organization. And that was very, very beneficial for us. Now let's shift to the right-hand column. What are the lessons for older adults? First and foremost, always have a plan for your retirement, how you will fund it, how you will be cared for if you need additional care, where you will live, and how you'll make that possible. Make that a good plan. And then you know what? Develop a plan B, because the pandemic told us that you might not always have plan A. You might all of a sudden have to live with a plan B. So good to have a plan B. And then stress test both of them. Ask yourself some hard questions. If this, then what? If my investments, instead of accumulating and growing in healthy percentages every year, all of a sudden declined and the markets went south, how would I be able to afford my retirement? And finally, share those plans with your support network. We often hear older adults say, well, if I need help, my son or daughter will be there. And then the next question, of course, is, do they know that? Have you had the conversation with them? Do they know what's involved? So those are the lessons that we've learned from COVID as an organization that's been in business 54 years, supporting, honoring, and uplifting older adults. Let's now shift to our expert speakers that we have with us. It's my pleasure to introduce Howard Gleckman. His topic is going to be navigating in an uncertain world. Howard is a senior fellow in the Urban Brookings Tax Policy Center at the Urban Institute, where he edits the fiscal policy blog Tax Box and a daily newspaper, The Daily Deduction. He is also affiliated with Urban's program on retirement policy, where he works on long-term care issues. Before joining the Urban Institute, Howard was the senior correspondent in the Washington Bureau of Business Week, where he was a 2003 National Magazine Award finalist. He was a 2006 and 2007 Media Fellow at the Kaiser Family Foundation and a visiting fellow at the Center for Retirement Research at Boston College from 2006 to 2008. Howard writes 2 regular columns for Forbes.com on tax policy and elder care. He is author of the book Caring for Our Parents, and he speaks and writes frequently on long-term care issues. It's my pleasure to introduce one of the smartest people that exist on long-term care issues and elder care, Howard Gleckman.
Lindsay, thank you. Thanks to you. Thanks to Cynthia. And it's great to be back at Goodwin House, at least virtually. I wish we could be together in person, but maybe we'll be able to do that again sometime soon. My job today is to give you some background on long-term care, also known sometimes as long-term supports and services. It's an interesting thing. Often when I say long-term care to consumers, people think I either mean long-term care insurance or they think I'm talking about nursing homes. But in reality, I'm not going to really talk about either one of those very much today. I am going to talk about what long-term care really is, the chances of needing it, where people get it, what it costs, how we pay for it, and then a little bit about some of the public policy changes that may affect care in the future. So let's start with a definition. What do we mean by long-term care? And to me, it means the personal assistance that people need to live the best possible quality of life that they can. At low levels, it means assistance with activities like transportation, cooking, and cleaning. At higher levels, it's help with getting it out of bed or eating, bathing, or going to the bathroom. This is an often terrifying, always confusing topic. It's clouded in myth and misinformation, and I hope before I'm done today, I can part at least some of those clouds. So let's start with demographics, which is really what this story is largely about. Lindsay showed a couple of slides before, and I'm going to talk about them in a slightly different way. It's interesting. The booming aging population that she showed on that slide is often described in negative terms. I think some of it is the ageism of our country, but we talk about the senior tsunami or the crisis of aging in America. It's important to remember, though, that the long lives of older adults is really a good thing. As somebody who's an older adult, it's a good thing for me, I'll tell you. It certainly beats the alternative. We are, in fact, living longer now than at any time in human history. Overall life expectancy in the United States has increased from 49 years to 79 years just since the turn of the 20th century. And that's the most rapid growth in life expectancy in human history. Just since 1950, life expectancy at age 65 has increased from less than 14 years to more than 19 years, thanks to improvement in medical technology and improvements in public health. Just think about antibiotics, indoor plumbing, and flu vaccines, to say nothing, of course, of COVID vaccines. Now, COVID may have knocked that growth of life expectancy back a little bit, but assuming we get the virus under control, it'll turn up again, particularly in old age. And much of the decline in life expectancy you've read about is really not from older adults. It's really from people in their 50s. And much of that is largely because of drug abuse. But you think about what's happened just in the world of medical technology. From 1989 to 2015, the mortality rate for women with breast cancer dropped by 40%. That means for many women, we've turned breast cancer from a terminal disease into a manageable chronic condition. But there's a downside to this. It means that people are going to live to older ages, and the US has never created a system for caring for the very old, especially those who, for one reason or another, have limited or no family support. As more of us need care for a longer period of time, there are fewer family members to provide that assistance. And the healthcare system certainly is not set up to provide long-term care. So about 14 million people of all ages need long-term supports and services today. About 60% of them are older adults, but 40% are actually younger people with disabilities. And the interesting thing about them is many of them are living much longer than they used to. For example, if you were somebody with Downs, you likely died in your 30s. Now you can live a normal or close to normal life expectancy. That number of people who will require long-term supports and services, 14 million now, will double in 20 years. 2/3 of those 65 and older will need a high enough level of care that they trigger a long-term care insurance benefit or become eligible for Medicaid LTSS if they qualified financially. 2/3. Men will require a high level of care for an average of 2 years, women a little longer, an average of 3 years. And it's also important to remember that the need for care is highly correlated to age. We made a big deal back in 2010 of the fact that baby boomers were turning 65. Well, the reality is 65 doesn't matter much. Your health at 65 isn't much different from your health at 55. Where it begins to change is when you get into your 70s and 80s. Lindsay showed the number of people in their 70s, but really only 10% of people 70 to 74 will need personal assistance. By the time we reach 85 to 89, less than half of us, about 44%, will need that care. So a significant increase, but still less than half. By the time we hit 90, 2/3 of us are going to need some long-term services. So this really is a story of not just old age, but very old age. And more of us are reaching that old age, or that very old age. I mentioned a minute ago that a couple of years of care is typical for men. 3 years of care is typical for women. But beware of averages. The real story about long-term care is about the broad distribution of risk. 1/3 of us, as I mentioned, will never need a high level of long-term supports and services. But 14%, 1 out of every 7 older adults, will need care for 5 years or more. And that care is going to cost $250,000 or more. For those people particularly, their lives are powerfully affected by changes in social structure and demographics. And think about this a little bit. In 2010, there were 7 people of caregiving age for every person who needed care. This is kind of another way to describe what Lindsay showed on that slide. So 2010, there were 7 people of caregiving age for every one who needed care. In 2030, just a few years from now, there'll be just 4. And by 2050, there'll be only 3. And that's not just paid aides, that's family members as well. 25% of older adults live alone. Half of women 75 and older live alone. That's because fewer of them are married, fewer of them ever married. There are more divorces, including divorces later in life. And of course, women still outlive their husbands. As a result, many more of us are going to live to a very old age, and we're going to have fewer family members to care for us. So the question is, who is going to replace those spouses and children? While nursing homes get a huge amount of attention these days, and that's not surprising given the many who died from COVID in long-term care facilities, it's important to remember that relatively few older adults get their care in long-term care facilities. Of the 13 million who need care, only about 5% or 700,000 live in nursing homes. Another 700,000 or 800,000 live in assisted living or similar congregate care. The other 85 or 90% get care in their own homes. Now, they may be the homes they raise their children in, they may be independent living communities, but they are their own homes. So long-term care is really not a nursing home story. It's mostly a story of those who are aging at home. Nearly 85% of them get all their care from family and friends, spouses, adult children, grandchildren, and neighbors. Only about 15% have paid aides. Those aides are very poorly paid. They average about $11 an hour before COVID. It's up a little bit now. And they will often get no sick leave or no retirement benefits. They also have among the highest injury rates of any occupation in the United States. In fact, you're more likely to be injured if you're a home care aide than if you're a coal miner. These are mostly back injuries and actually depression. Yet, long-term care is incredibly expensive. Even though so much of care is labor, it's still incredibly expensive. A nursing home in the DC area costs an average of $125,000 a year and up, and most of them are more than that. A good assisted living facility starts at $60,000 and rises with care needs. A full-time aide at home costs about the same. The average American has financial assets at age 65, roughly equal to the cost of 1 year in a nursing home. Fewer than 10% have long-term care insurance. And these costs are rising. Labor costs, as I mentioned, are going up. Personal protective equipment, which we've heard so much about during the pandemic, masks, gloves, gowns, those costs are up, and those are costs that are going to continue. Those are not going to end with COVID. For many older nursing homes, internal design is not conducive to infection control. They're going to have to engage in a massive recapitalization. Double rooms, which are standard for many people on Medicaid, or even quads, are probably going to go away. So either those costs are going to be passed on or the facilities are going to fail. So the question is, how are we going to pay? Few of us have enough savings. Few of us have long-term care insurance. For the most part, Medicare does not pay for long-term care. You may think it does. It doesn't. There are some very limited programs that do, but generally Medicare pays for medical treatment, not for long-term care. Medicaid is the federal government program that does pay, but it requires you to be impoverished in order to be eligible. And impoverished in most states really means impoverished. It means that you cannot have financial assets in excess of $2,000. So we're talking about really impoverished. Of the 4 million people who receive Medicaid long-term care, only about 4 million of the 14 million are in that category. The rest pay for care out of pocket or rely on care only from their relatives. And that means for many of these families, this is a disaster waiting to happen. So what's the policy response to all this? Well, the good news is that in the wake of COVID and its catastrophic effects on older adults, government is paying more attention than ever before. President Biden proposed to increase the federal share of Medicaid home and community-based care by $400 billion over the next 8 years. But it would only benefit those on Medicaid. It would only benefit those getting care at home. My sense is Congress is likely to expand the federal contribution to Medicaid home and community-based care, probably not by $400 billion, but by some significant amount. So what about everybody else? What about the 2/3 of us who are not eligible for Medicare? There is an effort to create a public long-term care insurance program. Washington State has created one, what they call a front-end program. It will pay $36,000 for your first year of care, and then you're on your own. Other states, California, Michigan, Minnesota, Illinois, and Hawaii, are all considering ideas for state programs. And in Congress, there's legislation to create a catastrophic long-term care insurance program. And the way that would work is you would be required to pay for the first year or two of care on your own, and then the federal government would pay a daily rate for you for the rest of your life. But these are not likely to be enacted anytime soon. They're funded with an increase in payroll taxes, and there are not a lot of politicians right now interested in raising payroll taxes for this purpose. And because they're funded by payroll taxes, it means that those people who are already retired are not likely to benefit from the program. So to just sum up, we are living in an extraordinary era of disruption in the long-term care world. It's never been like this. More of us are going to need care. There are fewer of us to provide the care, and the care that will be available is going to be more expensive than ever. That's going to be an enormous challenge, and you're going to need to prepare for it. What can you do to protect yourself? We could talk a little bit about some of the non-financial ideas, and my ideas actually are very much like those that Lindsay presented to you: plan and communicate. But I'll turn it over to Tom now, who's going to talk about some of the financial things you need to think about as you plan for this need. And I'll say one more time, 2/3 of you are going to need. So thanks very much.
Howard, thank you. You have a command of facts, and facts are friendly. Whether we think they are or not, they help us get wiser and they inform us. And you have such a skill at unpacking many complex topics and bringing them down to a place of decision making. And I'm delighted that we have another expert who is also of that same talent and will take it to what are some of the solutions. That next expert is Tom West, and he will present on the topic of Think Ahead. Tom is a partner at SEIA, Signature Estate and Investment Advisors, an investment management financial planning firm. And as part of Tom's focus on older adults, he launched the Life Care Affordability Plan in 2018. It is a fixed fee financial planning and asset management solution to help navigate changing healthcare needs. Tom has been a tireless volunteer for many nonprofits and local government groups with a focus on aging well. He is currently the vice chair of the Goodwin House Incorporated Board of Trustees and previously served in leadership positions on the boards of Insight Memory Care Center and the National Capital Chapter of the Alzheimer's Association. He is a sought-after commentator for Barron's, Investment News, and the Wall Street Journal. Welcome, Tom.
Thanks, Lindsay. And again, appreciate the introduction. You always make me feel awesome about myself after hearing that stuff. So I appreciate it. And thank you, everybody, for tuning into our program that we're putting on through Goodwin House at Home today. I spent a little bit of time trying to think about the right way to speak to good decision making on all things financial and healthcare for the 10-15 minutes that I'm going to be speaking to. And what I decided on, reflecting a little bit on the large demographic changes that Howard was talking about, some of the expenses that we're dealing with care, I wanted to at least come up with a quote or an idea that sort of respected the challenges and the challenging environment that we live in, but also giving us a little bit of fortitude in our collective capacity to persevere and to overcome. So there's a quote, a lot of you in the audience sort of know this quote, but I'm going to start with this. It's the beginning of the Fisherman's Prayer. There was a plaque that Admiral Rickover gave to John F. Kennedy that he put in the White House. The beginning of the prayer was, "Oh God, thy sea is so great, my boat is so small." And the context on why I'm giving that particular quote is, sometimes when you're trying to make decisions in the face of huge forces that are much bigger than you or much bigger than me, sometimes the idea of taking proactive steps can sometimes feel overwhelming. And I want to sort of take that quote and spin it a little bit different. When I hear that quote, I think like rule number one is you really need to know how to sail that boat. All right, really important. And the comments that I'm going to be speaking to in the face of COVID, in the face of the future of long-term care in this country, really sort of speak to what are the best ways from a decision-making standpoint that everybody in the audience give themselves sort of the best chance of getting the best possible outcome from a family standpoint, a health standpoint, and a wealth standpoint through the years ahead. So I really have sort of two themes in my comments. And the first one is, Tom, how do you make plans in the world of the unexpected? The COVID-19 or the bank challenges that happened in 2008. We're in a world where the unexpected happens so frequently and it overwhelms. I'm going to actually take that again, the concept a little bit different way. The first thing that I'd like everybody to consider is, how about we start with expecting the expected? As Howard was talking about, we have a pretty good idea from lots and lots of established data sources that most of us are going to age to ages that really weren't possible 10, 15, 20 years ago for large swaths of the population. And the overwhelming likelihood, 2/3 of us are going to need some kind of help in some way, shape, or form. And there's 1 of 8 of us that's going to need extended help that could be cognitive related, it could be really expensive. And why don't we start our planning by expecting that which is expected and making plans about it and considering ourselves the fisherman in the boat that recognizes there's some big things that are ending up happening, but my responsibility and where I really have agency and control is how I'm able to manage my own vessel. And when we're thinking a little bit further about this concept and the metaphor of a boat, I'd also want to remind you in a positive way that, boats aren't built to stay in the harbor. Boats are built to be able to sustain all sorts of different weather conditions out on the high seas. And I wanted to give you also a piece of good news that we know, just like Howard said, living longer really has some really positive spins to it. One piece of good news through the environment that we're living in is it remains true that preparation and planning usually get better outcomes for people. And winging it usually gets less good outcomes. And completely denying things that should be pretty expected usually gets the worst outcomes. So we're focusing, and you see the headline of what we were talking about today, planning and thinking ahead. Let's consider my second piece. When confronted from a decision-making standpoint with so much uncertainty, I don't know how long I'm going to live. I don't know what kind of help I'm going to need. And with those two uncertainties, amid COVID, amid this unprecedented restructuring of the way that the United States is trying to integrate housing and healthcare for their senior population, among all of the other challenges that we've got, where is it that we can get information and decisions that we can control? And my second point is, maybe the focus in times of uncertainty should be turned inward. Maybe there's a place where we spend a little bit more time reflecting and knowing ourselves. And there's sort of two different levels to sort of knowing ourselves. The first one is, consider what your circumstances are about your financial situation and your health situation and what your family situation is. And those are appropriately, those in the audience like, okay, that sounds awfully simple. I'm not sure how helpful that is. But I'll give you a tip. Don't do it with you in the first person. Think of profiling yourself as somebody, as a third person. If somebody were to profile you from a wealth standpoint and a health standpoint and a family structure and communication standpoint, how would you profile if somebody else did? I'll give you an example. There was a conversation that I had with a close family member who was having a minor scrap with another relative about something or other. And a comment was made, well, it's a good thing I get over things quickly. And I, as a third party, was able to say, like, no, you don't. You hold grudges like nobody I know. She said, oh, it's not true. Give me some examples. So here are the examples. And she reflected on it. She said, all right, well, I think you're right. And I don't think I would have thought of that myself. So maybe part of this idea of knowing thyself is making sure that you've got somebody objective that cares about you, that's literate in your situation, to also help you have a good understanding of what your wealth circumstance look like, what your health situation it looks like, and how your family structure and your support situation, how that really looks. Get a second opinion. And when we're going down this idea of knowing yourself and profiling yourself, one of the things that our practice and some of the things that I've seen professionally can really help is, why don't you think about reflecting on what's your ability right now to make effective and timely decisions. And for most of us in the audience, well, it's pretty good. Just check. Make sure that you're able to go back and look. Decisions that I've made through COVID, through the last 2 years or 3 years, about my wealth, about my family situation, or about my health care. Have those been good decisions? Is my decision making, likely to stay the same? If it changes, do I have a good support network in place to be able to give me the highest probability of getting outcomes that are consistent with what my values are? That's something to reflect on. There's another area that I think is important when you're considering knowing thyself. Do you have the ability to ask for help? I was thinking about this concept of asking for help, and I'm reminded that CEOs, high-profile athletes, Michael Jordan, Tiger Woods, people at the absolute top of their profession or their field, they are regularly asking, reaching out, soliciting for, like, what do you think about this thing with me? What's your perspective on ways that I might be able to improve this? I'm feeling like I have a little bit of weakness in this one particular area. How can I get some support? And if I can't do it myself, what are the resources that I need to put around me to get better outcomes? And I use those sort of paragons, those examples of the best and the brightest of us regularly asking for help. And I just want to consider, well, what about the rest of us? The rest of us sometimes are reticent about asking for help. And when we're considering parts of our lives, whether family or our wealth and our health, I want you to consider, again, profiling yourself. If I need some assistance with something, am I somebody that's able to communicate well, effectively on some of these different topics, and maybe seek out some assistance or get somebody to double check what my thinking is going to be? That's an area of sort of self-awareness that can drive some better decisions on all of these different fronts in your life, to be able, again, to get some of those better outcomes. And again, go back to sort of two of my themes. What have we learned about our ability to ask for help during the pandemic, around those different spectrums? What have we learned about our ability to ask for help around, expecting the expected? We're all going to probably get older. We are going to get older, and most of us are going to need some kind of help. What is our capacity to be able to reach out and ask for assistance along these fronts? I think that that's a material variable that drives good outcomes, is the capacity to ask for help to begin with. When we're thinking of profiling ourselves further, it's also useful to think about what kind of situations exist in the world, because none of us are perfect, but what kind of situations most predictably take me off my game about being effective in my own choices. The best decision makers out there from a psychological standpoint, they already know what their weaknesses are. They've communicated their weaknesses, and they're more ready to be able to round out the resources around them to be able to support. And it's also, when you're profiling yourself, what are areas that might be giving us the most trouble? And I'm trying to walk the walk a little bit. I have a ways to go on this, but just as an example, in preparation for this very presentation, on Monday, coming back from vacation, couldn't find my notes for what I was preparing. I emailed Lindsay, do you have notes? She gave me the notes because she knows, and she's prepared, and she's a resource for me to know that sometimes management of details is something that I need some additional support on. So I'm working on that. I'd invite you to consider, are there areas about my ability to be effective that put me under pressure? And I want to give you some examples that are a little bit less trite than my notes. Are you a decision maker that tends to be sometimes conservative to a fault? And here's what I mean by conservative. Everything staying equal, it makes me feel more regret if I take some action and it's wrong than if I do nothing and it ends up driving worse outcomes for me. If you're somebody that is inertia is something that you're challenged with to sort of get off the dime and to get started, that's something that you should be communicating to people that care about you, to advisors that are around you, to be able to help you walk through what's the next least action that you can take to be able to make some progress on whatever the path that you have ahead of you. Another example of things that might put pressure on your decision making, are you somebody that really likes to do things only your way? There's one of my quotes, there's two ways of doing things, my way or the wrong way. If that in some way sort of speaks to you humorously, just consider what that implication is going to be sometimes down the road. Ways that you can double check this, or you can ask somebody to sort of test you on it. Do I really seek information that I already believe? Do I really go out of my way to avoid challenging my beliefs and my worldviews? If that's a challenge, you want to be able to identify that and articulate it. And last thing that I would say from a profiling standpoint, I'd like each of you to ask yourself, what is it right now that you're procrastinating? What specifically is it? A year ago, when I did this program with Howard, and I really enjoyed myself there, I made a big point of telling the audience to write everything down. Well, I'd invite you as sort of a takeaway for this particular time is, what are you procrastinating? And write down, what specifically is it that you're procrastinating? And, you can say, well, listen, we're in the middle of COVID. I don't know what's going on. I have to basically put my world on hold. And I'll give everybody a pass for procrastinating some important decisions. But I would also make it incumbent upon all of us, in terms of being effective decision makers down the road, to be able to say, all right, we're starting to see what a post-COVID world might look like, hopefully on the other side of this Delta variant coming through. But if you can identify what specifically are the decisions that you're procrastinating, identify specifically what they are. And coming around a little bit more to our topic at hand, my wife and I just became empty nesters, and we procrastinated doing a whole bunch of home renovations. On deck is redoing the bathroom and the bedroom and maybe some work in the kitchen. We procrastinated that. We're just starting right now. And the cost of our procrastination looks like this. Everything is dramatically more expensive than we thought. And right now, we can't even get a bid on somebody wanting to do the work. So we're having to go back and think about this as a much more significant option than we had expected. If you identify what the things are that you're procrastinating, you have a better opportunity, I think, to take steps to be able to move through them. And when we get to the question and answer side of things, we'll be able to go into more detail on specific finance and whatnot. But I wanted to keep decision-making comments pretty general here because that's what's most suitable for the time that we've got. And then the last lesson that I want to leave you with, think about what COVID has taught us about personal responsibility. Think about what COVID has taught us about the need for us to be accountable to ourselves, to others, to people we care about, to sort of society in general, and use that lesson that I won't spell out for you. I'd like to think that the audience is pretty adept at seeing what personal responsibility really looks like in this time and age that we're living in. But apply that to your own self, your own self-profile, your ability to know yourself. All of us individually, are the ones that are personally responsible and most accountable for what happens next. And when we talk a little bit more about steps that we're going to take about our health, our wealth, and our family, and the question and answer side of things, I'd sort of close with that. So again, high points, expect the expected in a universe of the unexpected. And number two, when faced with a lot of ambiguity, the best place to be able to put time, energy, and attention in circumstances like this, I believe it's inward. Measure yourself as if you were profiling across your wealth, across your health, and across your family circumstance. And think about some of those other pointers that I had that might impede you or your family's ability to drive effective decisions in the face of a lot of this uncertainty. So with that, Lindsay, I'll give it back to you. And I know in the question and answer side of things, we'll be able to get into more specifics that the audience is generating.
Thank you, Tom. So I would interpret Howard as giving us facts about society, and you, Tom, is encouraging us to be sober and self-assessing about the facts about ourselves. And I'm going to pivot off that for the first questions, and I'm going to direct the first one to Howard. Howard, you said that in our country, it is no longer a story of old age, but of very old age as we live longer. What does that mean for society? And what does society's response to that fact mean for us as individuals that are responsible for our aging well?
So it's an interesting thing about Americans. We struggle with aging. You know, we think about raising children as a normal part of the family life cycle. The government provides massive subsidies to families to care for children. But for some reason, we separate out the care for older adults. That's kind of treated as something else. And part of it is because aging makes us afraid. Certainly death and dying makes us afraid. This is not something that's true around the world, but it is something weird about Americans. And I think one of the things we're going to need to do as the population changes is to think about where older adults fit in society and in the community. And not just as, you know, takers of resources, which too often is the way they're thought of. It's also, what can they contribute? You know, the older adults can still work. Older adults can volunteer. There's a lot that they can contribute. And we don't think about that either. We think about older adults, when we think of them at all, as people who are helpless. So I think this is going to require a profound change in the way we all think about aging and the way we think about our life cycle. And that's not going to be easy, but I think it's really important.
So, Tom, I'm now going to bring it to you. Humans often assume the optimal outcome about their own lives. How many have you seen be so lucky to have the optimal outcome about aging? And what tends to be the reality for most?
Well, you know, when I read that question, Lindsay, it's a good question. I had three thoughts. The first one is, just because something happened to somebody else doesn't mean it happens to you. You know, and I always want to sort of preface that, where but I'd say, loosely speaking, and then I'm reflecting on an answer that I gave a year ago, there's generally three different cohorts of folks in terms of this planning ahead for aging. And if you think of the planners that, you know, try and endeavor to, you know, work regularly on putting attention to wealth and family and healthcare, that generally is 30 to 40% of the population around the Washington, D.C. area, and attracts quite a bit to some personality or temperament types, levels of education, levels of wealth. There's a handful of things in there that I'd probably say that are consistent. There's a middle population that I think have one or two areas that might be their downfall, but generally speaking, they're doing most of the stuff right. They've saved, they've kept their expenses in order, they go to the doctor, they eat well, but maybe they haven't rounded out their legal documents or worked out their successor decision makers in a way that somebody would be able to speak or act for them at a time of need. That group is probably, again, I don't know, about a third, where, you know, there's a sort of an analogy of, you know, but for a nail, the kingdom is lost. That I think that it's that population that I'd certainly like to speak to, and I really appreciate serving in my professional life. You know, how can we button up loose ends with folks that might have procrastinated, that might have not taken care of all of the different loose ends? And then as the question sort of led, there's a cohort of the population that is just going to crash into the system and drain resources from other folks. And that sort of speaks back to a little bit about personal responsibility and accountability. I don't think we've ever seen that as, you know, regularly profiled in current news as you see in the middle of COVID. But just the bridging concept to the last question, you know, what does it mean for the future of society and whatnot? There's certainly a lot of dialogue out there about we're not caring for each other as much as we should or as much as we used to. I'm always, as a thinker, somebody that starts with, well, before you start talking about other people, start with yourself. Are you taking care of yourself? Are you doing the stuff that you need to be doing for you? It's sort of the metaphor of, put your own mask on before you put the air mask on the person next to you. And I think that if we collectively, as we're thinking about aging and housing and healthcare and whatnot, do for ourselves first that which needs to be done, it can put all of us in a better circumstance to be able to lend a hand in a way that we aspire to.
If I can jump in for a second, it's an interesting question because I think that the optimal outcome is different for everybody. Right? So your optimal outcome may be when you can no longer care for yourself, you want to move in with your daughter and your grandkids. They would love to have you, and you want to be there, and that's your optimal outcome. My optimal outcome may be the last place I want to live is with my kids and my grandkids. I'd rather get hit by a bus than do that. So I think it's important to keep in mind that all of us have different optimal outcomes. We have different goals as we age, and I think whether it's financial people or policy people, I think we need to keep that in mind.
Yeah, and thank you, Howard, because I think that there's a flavor of my comment that could have been interpreted as consensus on what best outcomes are. It still remains the point that that there's so much variance right now in the way that older adults are treated, okay, that preparation and planning still is the best prescription to drive whatever personal outcomes that you're looking for. But thank you, that nuance is important. I appreciate that.
I'm going to now go through a few questions that focus on long-term care insurance. Here's the first one. Can long-term care insurance be seen as a way to pay for a home aid so that an older adult can remain in their house indefinitely?
Got it. All right, so I'm going to repeat just the question for everybody. Long-term care insurance, is that sort of the best option or a sufficient option to be able to take care of me in my own home, particularly given a potential constraint that the policy only covers for 3 years? I've got sort of two different ways to think about it. The first one is, remember that the overwhelming number of these policies are not written with a strict time limit. They're written with a dollar limit that is calculated by what the benefit is that the policy pays out per day, typically times 365 days a year times 3 years. So generally speaking, a 3-year policy would be a few $100,000. And the answer to the question is, it depends on how long a few $100,000 is going to stretch, what your care needs are going to be, and what your additional spending might be. The variables that you would want to consider to optimize that policy that you've got, and I'm glad you have that policy, is make sure that you're accounting not just for the cost of care, but also for any of the costs associated with keeping up the house. So you still got groceries, you still got your property taxes, so on and so forth. And sometimes when people are making forward projections, they sort of forget all the other stuff beyond the cost of care. So for many families, a 3-year plan might be sufficient. I think the only way to be sure is to check and to do a little bit of projections about what total expenses might be, what other income sources that might be, and how that long-term care insurance supplement can get there. At a minimum, it can cover the front end of a period of care and buy you plenty of time to figure out what the next step is in the event that that isn't sufficient.
That is a really good point to think of it as a bridge to being able to make another decision. So here's a follow-up question to that. Is there an age that it is too late to purchase long-term care insurance?
Generally speaking, the long-term care insurance that most seniors are talking about right now, retail long-term care insurance that was sold by a large number of carriers from the early 90s to the mid-aught years, somewhere in there. By and large, that kind of long-term care insurance really doesn't exist anymore for new purchasers. And a lot of the discussion that we have on long-term care insurance is, what do I do or not do with this policy that I bought back then? Your question for new purchasers coming in, through a combination of factors, the insurance industry isn't issuing those kind of policies anymore. And the most prevalent structures that I see are some hybrid life long-term care insurance product that ends up being quite expensive because you're paying not just for a guaranteed death benefit, but for the long-term care insurance benefits. So with those kind of policies, it's as much an affordability issue as it is an age issue, because those contracts tend to be significantly more expensive, to the tune of potentially approaching $50,000 to $100,000 or more of premium going in, like in that kind of a neighborhood. And I would say that age, of course, is a factor. It becomes significantly more expensive on an accelerating rate in your late 60s, early 70s. But I'd invite Howard just to talk a little bit about long-term care insurance and anything else that is out there on the market or might be coming for a minute or two.
Sure. Tom's right. I think for traditional standalone long-term care insurance, very few carriers are selling it. They're selling it for very limited coverage periods, and they're underwriting very, very strictly. So if you wait very long, if you wait even into your 60s, they are likely to find some pre-existing condition that they will use to deny you coverage. So the standalone policies, they only sold 50,000 of them last year. As Tom said, is a business that's almost extinct. For the combo products, combining long-term care insurance rider with an annuity, for example, or a whole life policy, underwriting is less important because they're going to pay you one way or the other. But they are very expensive, and you need to be able to afford an annuity before you can even think about this. And for many people, that's really just not in the cards.
So here's the next question then. What are the limitations of long-term care insurance based on real life scenarios?
Start on that one, and then Tom can jump in. So it's an interesting thing. I think it's a great model of the human responses that Tom was talking about. You have, for example, the planners, the excessive planners, and then you have the deniers, right? So the problem for the excessive planners is they tend to actually buy too much long-term care insurance. They tend to wildly overinsure. Remember I said that on average, you're going to need care for a couple of years if you're a man, 3 years for women. People are out there looking to buy 7-year, 10-year policies when, at least on average, they're not going to need them. Then there are those people who are in denial, who don't buy long-term care insurance, they don't save, they don't do anything. So I think the biggest constraint isn't really about the policies. The biggest constraint really is about us and our brains and our inability to properly plan for needing help in old age. And as Tom said, we either plan too much or we don't plan enough. I don't know how many clients you have who hit the sweet spot, but I suspect probably not a lot, at least not without your help.
Well, my clients do.
Your clients are great. I mean,
I'd say it's a really good question, and I'm glad you spun it with decision making. So narrowly, Lindsay, I think sometimes folks will figure if I bought long-term care insurance, and it's sort of a set it and forget it decision. And I think practically speaking, the two areas that I think long-term care insurance, sometimes people underestimate is, number one, there's still some administrative responsibilities to getting a claim paid on time to the right person appropriately. Happily, the long-term care insurance industry still pays out the overwhelming majority of claims submitted, so we got that going for us. But there's a handful of things that people end up being surprised that aren't covered. Something called the IADLs, things that would be medication management or help with transportation or managing a checkbook or things like that. That's not what long-term care insurance pays for, but it might be lessened abilities that prevent somebody from living independently in the same way that they used to. So there's a gray area where sometimes abilities are declining, but that doesn't meet the criteria to make a claim, which is typically needing help, eating, dressing, toileting, transferring from vegetarian, bathing, continence, that sort of stuff, or cognitive impairment separately. So that's sort of item number one. There's an administrative thing, like who's filling out the forms? How do you make sure that whoever the ultimate payer is getting reimbursed? What's the setup for people reestablishing validity of claims? So there's a little bit of work that needs to be done, and sometimes senior housing and healthcare providers can do that, but that's item one. Item two with the long-term care insurance is it doesn't say anything about access. It just is it's an additional supplemental funding source to reimburse expenses from somebody that a lot of times the consumer themselves needs to go out and find after the fact. So just because you have long-term care insurance doesn't mean that you have the person that you want taking care of you the way that you want when you want. You know, it's a situation where think about my bathroom in my bedroom redo. Like, we can afford it. I've got it all ready to go. I can't find anybody to do it. I can't find anybody even to put a bid on it. And I think when you're considering the potential constraints that Howard was talking about with the availability of labor, and don't forget, there's a lot of people that are retiring the same age with the same financial circumstances and the same priorities, all competing for what I think is going to be more and more scarce resources. Long-term care insurance is just a funding source, but it doesn't necessarily put you first in line for the stuff that you want. So there's a loose end and a planning standpoint that I think needs to be addressed that people sometimes forget when they're considering long-term care insurance as sort of a set it and forget it decision.
That's a really good point, Tom, and it's one of the reasons that the very first credentialing icon I referenced for Goodwin House Incorporated was being a top workplace. Goes back to it's not just affordability, it's accessibility. And for all of our guests, whatever partner you choose, wherever you choose to live, do have a senior living and healthcare services partner that focuses on your workforce. So you'll have not only the care, but the quality care you want in your older years. Gentlemen, another question. The pandemic has brought on dramatic spending sprees at all levels of government. At what point will the day of reckoning come, and how quickly will policies that affect older adults take effect? I'm 77 years of age. Will I be expected? And how do you see this situation playing out for the various Medicare, Social Security, and other government supports that many of us may have some plans to use?
So we're in a very strange environment. The budget deficit is going to numbers we haven't seen since World War II. And the questioner is right. I mean, this is a matter of some real concern. Think about it in two ways, though. There are the temporary spending increases in tax cuts, which were largely responsible for the giant increase in the budget deficit during the pandemic. Budget deficit went from $1 trillion, which is bad enough, to $3 trillion, which is sort of unimaginable. But much of that's going to go away because a lot of that spending was temporary. The economic impact payments that people got, those were temporary. So that's not so much of a concern. What's more of a concern is the built-in costs. And many of those built-in costs are actually to support us, to support older adults. So it is Medicare and Social Security. If I were 77, I wouldn't worry at all about whether or not I'll continue to get my Social Security benefits. Congress is going to take that away. Congress at the moment, as far as Medicare is concerned, is talking about expanding Medicare. We're not cutting it back. It's very likely that Democrats by the end of this year will pass this so-called reconciliation bill, a big social spending bill that's going to expand Medicare benefits to include dental and eye care and vision care. So we're going to keep spending on Medicare. If I weren't 77, if I were instead 37, I would worry a lot about whether or not I'm going to get promised benefits in Social Security. And I certainly would start putting money away because the over-under on that is that you're not going to get the promised benefits. So in a weird situation, very few politicians want to raise the taxes they need to pay for the services that the government wants, and most people say they need. So we'll just keep borrowing from the Chinese and from other people as long as they're willing to lend us the money.
Mm-hmm. I think my comment on that, these are conversations that I have pretty regularly. What's important about the answer is to drive what is actionable out of this conversation. You know, the federal deficit, problems with bonds, interest rates, whatever it might be, that is a circumstance much bigger than me, than you, than whoever it is that I'm talking about. And it gets me back to the quote that I started with, oh Lord, the sea is so big and my boat's so small. Like, what's actionable specifically? Because from a decision-making standpoint, there's so much coming at us from different news sources, some of which we probably shouldn't be listening to as closely, that tax our bandwidth in terms of making decisions. And we're at a critical enough time, if you let me go back to the metaphor again about you better be sure how to sail your own boat. What is actionable in the sets of decisions that you need to make regarding this conversation? Because if the answer is nothing or minimal, or maybe you build a scenario that says my taxes are going up to confirm or not confirm that I can afford it, I regularly redirect those kinds of questions to that which is actionable and that which is something to think about, but not necessarily something that we really need to go through from an advice or a profiling standpoint. And I'd invite everybody in the audience, and I appreciate the question very much because it's on everybody's minds, but trying to drill down for all of us individually, what is actionable? That's probably the best attitude to take towards those really large influences.
So in a similar vein, we've not talked about pharmaceutical products and what potential they offer to stave off any number of illnesses or diseases that would decline our capacities. Most recently, there has been the dementia drug that's been in the news. Howard, what's your outlook for that?
So I talked before about the tail risk, those people who need care for a very long period of time. Many of those people need that long spell of care because they have dementia of some kind. It's a terrifying disease. People know about how it progresses. It can be awful. For 30 years, researchers have been trying to find a drug that will either delay onset of dementia or somehow cure it, and they failed. There's no drug on the market that does anything. No matter those ads that you see when you watch the news, there is no drug. About a month ago, the FDA approved for the first time a drug from the drug company Biogen called Aduhelm. And they approved that drug not because they thought it would have a clinical benefit for people who have dementia, specifically Alzheimer's disease, but because they thought it might have an effect on a change in their brain that might be responsible for Alzheimer's disease. So it's this kind of rim shot that they did. Without getting too technical about it, people with Alzheimer's disease have high levels of a protein called amyloid beta in their brain. We know that. We don't know if amyloid beta actually causes Alzheimer's, or if there's something else that causes it that also causes this buildup in this amyloid beta. We don't know that. Research has been arguing that for decades. The FDA said, well, we don't know either, but we're pretty sure that this drug will reduce those amyloid beta plaques in your brain. And we hope that by doing that, it will have some positive clinical benefit for people who have Alzheimer's disease. So a few things to know. First thing is, this is only about Alzheimer's disease. If you have another form of dementia, Lewy body dementia, vascular dementia, there's no research, no evidence at all that this will do you any good. There is also very little evidence, actually no evidence, that this has any benefit for people with moderate stage or advanced stage dementia. Whatever benefit this may have, and it may not have any, but whatever benefit this may have, it will have only for people with early stage Alzheimer's disease. The last thing to know is this drug will cost $56,000 a year, and you're going to have to take it every year for the rest of your life. So it is unimaginably expensive. We don't know yet whether Medicare is going to pay for this or not. This isn't a typical Part D drug that everybody's got a Part D drug benefit for the drugs they buy at the pharmacy. This is not that. This is actually a Part B drug because it's given by an infusion. $56,000 a year, if 1 million people got it, would be $5.6 billion $56 billion, I gotta do my math right, $56 billion, which is more money than Medicare spends for all of its Part B drugs combined. So this is fabulously expensive. Medicare doesn't know if it's gonna pay for it. It doesn't know under what circumstances it's gonna pay for it. Even if Medicare does pay for it, you'll have to pay a copay, which is 20%, which is $11,000 a year for the rest of your life. You're gonna have a PET scan regularly. That's another $5,000 that nobody pays for. So this is a drug that probably doesn't work for very many people, may not work at all, is fabulously expensive, and there will be more like it coming down the pike. So that's what you should know. I'm not in a position to advise people on whether or not they should take a drug, but I'd have a long talk with your doctor before I made any decision. And the last thing you want to do is go into the doctor's office with a newspaper article you tore out of the paper and say, "Give me the drug." You need to have a long, hard conversation with your doctor to figure out whether this is really appropriate. And don't count on it to be the savior for us all. It's not going to be the boat.
Right. I think dementia and Alzheimer's has been sort of a passionate area for a lot of my community work for decades, and I appreciate the hope that can be tied with what sounds like a pharmaceutical breakthrough. But my response, Lindsay, is going back to my themes, like expect the expected. If there's only a very coincident chance of any impact, why don't you maybe put some actionable decisions on things that have a much higher degree of being impactful? The idea of, we know generally speaking that early interventions on different kinds of therapies and socializations in dementia at an early stage of a period of care is hugely impactful on the onset of symptoms when you move into the middle or the latter stages. Hats off again to Goodwin House and the Stronger Memory program that we've got there. Everybody, that's a curriculum that I'd invite you to look up. It's basically research-backed sets of exercises that increase the ability to recall different kinds of memories. That if I were going to be putting, what's actionable, pound the doctor's door down to be able to get this drug, or to be able to take some steps about early interventions or different kinds of clinically backed things that show measurable results. Again, I'm going to be the broken record. Expect the expected, and what's actionable about the news. That's where I think you can sort of orient good decision making.
Think about the opportunity cost. And for some people, $56,000 may not be much, but for most of us, it is. And think about what else you could do with that $56,000.
So, gentlemen, you have given us knowledge, and you have given us practical actions, and you've been incredibly generous with your time. I am so delighted for the audience that joined us today, and those that will see this as we post it on social media, and give, I hope, many, many others the benefit of the wisdom and the knowledge that both of you bring to what are critical issues for us as individuals and for our society. So thank you, Howard Gleckman. Thank you, Tom West. I'm going to do a few quick sign-off slides for our audience that share about Goodwin House resources. If you found this to be valuable and you want more content from Goodwin House, then you'll see on this next slide, we have 2 upcoming Goodwin House at Home briefings, an informational luncheon in Springfield, Virginia, and another that's taking place at the historic Blenheim location, which is in Fairfax. One on September 22nd, one on October 20th. And you see that website address, goodwinhouse.org/events, and you can see all the upcoming Goodwin House events. We also have many, many resources on our website. And just as today's webinar will be posted on our website for recording, many of our other highly valuable webinars with other experts are on the website. And you can see all these resources for older adults at goodwinhouse.org/resources/. And when you're there, go up into the search function and type up Stronger Memory, and it will take you to the page with our Stronger Memory, which is a brain health program, and you can access the curriculum free of charge right at the Goodwin House website. So with that, we're going to conclude our program, and we want to thank you so much for spending time with us. and taking important steps in your own journey to avoid chaos and to live and age well and benefit from the wisdom of Howard Gleckman, Tom West, and Goodwin House Incorporated. Thank you so much. Have a great afternoon and be safe.